Hello dear colleagues and friends, and welcome to our online webinar that is dedicated to a very important and interesting topic, like a basics of veneer preparation. This is the title of topic, and we got a lot of questions that we are going to share with you. The answers to these questions we are going to share with you, like for example, how much we need to prep, what should we do in case if we have caries defects or composite restorations, and how do we prep in case when we have rotations or crowding or similar clinical cases. I'm going to share with you all this information, and also I will share clinical case with mentioned problems, and will guide you step by step how do we solve the problem. And after that free webinar you will be able to understand a lot of basic principles of veneer preparation. So I will now start with the first question that we have from our colleagues: how much we should prep teeth for porcelain veneers. To answer these questions, we have to understand that the amount of preparation slightly depends on thickness of ceramic from dental technician. Okay? The thickness of ceramic also is based on two very important aspects. The first aspect is color change, and we have to understand that there is a certain thickness of ceramic veneer that is able to mask the color and to change the color that we would like to have. And another aspect is biomechanics. In other words, it is very important to understand where we will put or where we will bond our veneer to. Will we bond our veneer to enamel, or we have to bond our veneer to dentin or to composite? In these cases, there is a big difference in terms of thickness. So let us go deeper in that aspect, in these points. So first, to be able to understand how thick or thin veneer should be in order of aesthetic rehabilitation, you have to ask your dental technician, okay? And then your dental technician guides you, and you have to create space to dental technician. I want to share and I want to highlight a very important information at this point. If your dental technician says that he needs 0.5 millimeters, for example, it doesn't mean that you have to prep 0.5 from tooth surface, okay? You have to give 0.5, but there are some cases where you have already these 0.5 millimeters because of the position of the tooth, or because of the shape of the tooth, or because of the surface of the tooth. So if you have teeth that are retroclined or plain or flat teeth, and you have space to add, your preparation will be super minimal, or sometimes even non-prep, okay? But your dental technician in this case will have certain thickness for porcelain veneers. So if they say 0.5 or 0.8 or 1 millimeter, it doesn't matter. It does not mean that you have to prep that much. So how do we actually act in these cases? We plan the case, we analyze position of patient's teeth, we analyze data from dental lab regarding thickness, then we do so-called mock-up or smile prototype, and afterwards we start preparing teeth through the mock-up using depth cutting burrs to give that space for dental technician. Before preparations, you can also check this space by means of utilization, like prep guides or silicon index to control prep. So you can put this silicon index before you do preparations, and you can see already how much space you have for dental technician and how much you need to prep or how much you need to give to your dental technician. Okay, I would like to share with you some protocols that are available from the literature. This one is from John Caries, and this is the protocol that is based on color change and also on some biological principles of preparation. So basically, when you do preparations from the surface, you have to give your dental technician space, right? So we discussed that. And in average, it is from 0.5 to 0.9. It depends on the initial color of the teeth and the color that you would like to obtain in the final steps, let's say, of your treatments. Okay, this data that you can see here is average. It doesn't mean that you have to follow just 0.5 or 0.6 or 0.7 preparations. You have to discuss this with the dental technician. Okay, but what is interesting in that aspect is how do we deal with interproximal areas? How do we deal with interproximal contacts? So when you have caries defects, class 3 or class 4, or you have old restorations there, or new composite restorations there, let's say, when you have big black triangles between teeth, when you have tremors, when you have diastemas, when you have pegged lateral teeth, or you have to transform the teeth, or you have to change the shape of teeth, you have to open interproximal contacts, okay, to give your dental technician space there to make a new shape of the teeth. In the rest of cases, you can keep interproximal contacts. So when you keep interproximal contacts, you do so-called type 1 veneer preparation. When you open interproximal contacts, you do so-called type 2 or type 3 veneer preparations. If you want to know more about these aspects of tooth preparations, I mean types of preparations, I kindly invite you to participate in our new online masterclass or on our new online workshop that you may find on our webpage, online.belograd.com, and then you go to Complete Guide in Veneer Preparations. So this online workshop is completely about different designs of preparation. And I will demonstrate you step-by-step preparations like window prep, type 1, type 2, type 3, incisal overlap, and we will discuss in very precise details indications and step-by-step protocols. So that online masterclass will be on 24th of June, and there is a very important bonus like a support program from our side that will be 3 months after that online masterclass. It is available, this support program is available only for those who applied and booked their places before 24th of June. Okay, so let's go back to our presentation, and we are going to discuss cervical area. So when you do cervical area, you have 3 options where to localize finish lines. So basically we have supragingival option, gingival level, or intraclavicular. When we do supragingival preparations we can do in non-aesthetic areas, or in case when you have so-called patient with low smile line. And in this case you are not changing the color, for example. Okay, so you can do supragingival preparations. When you have patient with high smile line and you have to change the color, in this case you have to prep inside the sulcus to mask the transition between the veneer and tooth. Okay, that is important. When you have patient with a low smile line, for example, and you change the color, you can keep your preps at the gum level. So that will be more biological preparations, more conservative preparations, and more easier preparations in such a clinical cases. Okay. I want to ask you one question, by the way. I know that you are watching this webinar as a record. It's not live, and you can see you can hear my answer later on. But I would like to ask you right now, and to ask you also to write in comments the answer. So the question is, in which other clinical situation we have to do our preps intraclavicular? Okay, one situation is when you change the color of patient's teeth and you have patient with high smile line, so you have to mask a transition inside the sulcus. And the question is, what other clinical situations you have to go intraclavicular? Okay, you can put pause right now here on the video, write down your answer, and then we continue. Okay, so I will answer you. If you want to close black triangles, when you have these black triangles, or when you are doing treatments of diastemas or spacing between teeth, you have to go down with your finish line to give your dental technician space to provide so-called smooth and progressive emergent profile. Okay? We have to understand that the distance between interdental or interproximal contact and bone has to be not more than 5 millimeters. So the distance from contact point to the bone area has to be about 5 and less millimeters. In this case, you can expect that interdental papilla will fill this area. If the distance is more, you may still have blank triangles. Okay, so you have to keep this in your mind. So let's go next. According to tips and tricks about veneer preparations. The good thing when you do veneer preps is that you can keep planes. Your preparation is absolutely biological driven and biologically oriented. So we can keep biological principles of preparation. It is different when you prep for the crown. When we prep for the crown, the pathway of insertion is vertical. So when you have to put your restoration vertically, you have to remove bulbosity. So basically this bulbosity area will be merged with cervical and middle plane. And you know how thin enamel is there. And in most of the cases we have a lot of dentin exposure. So our preparations will be way more aggressive. Veneer is more horizontally oriented. I mean, the pathway of insertion for veneer is more horizontally oriented, and it is way more conservative. So basically, when you finish your preps, you can still see same planes as teeth before your preparation for veneers. Let us also discuss designs of incisal edge. We have two big groups. We have the group of teeth without incisal reduction, so-called window preparation, and we have another group where you have to do incisal reduction. When you have to do incisal reduction, or you decide to do incisal reduction, you also have two groups, okay? The first group, incisal overlap, when you go with your preparation to the palatal side or lingual side, and another group is butt joint. So you just reduce incisal edge and that's it. This is butt joint. There are many different studies that you may find in literature, but one of these I would share with you. So you can see the comparison between butt joint and overlap in terms of survival rates due to fracture. So you can see that overlap groups, even with a big overlap, with 4 millimeters overlap, and the thickness of ceramic 4 millimeters on incisal area, cracks more than butt joint. And what is interesting, the most of these cracks are from palatal side. And the reason why ceramic veneer cracks usually, often from palatal side, is that we have this fossa or concavity from palatal side, and where there is a function, there are a lot of elastic deformations from the palatal side, and these elastic deformations lead to propagate or to initiate crack line, vertical crack line in your veneer, in your ceramic. So this is actually a disadvantage to do so-called incisal overlap. But there is another disadvantage about incisal overlap, which is pathway of insertion. When you do any preparations from palatal side or from the lingual side, the pathway of insertion will be vertical. So in that case you have to prep more from the cervical area, and it is not good from biological principles of preparations. Another disadvantage for incisal overlap is that it is more difficult to prep. The design is more difficult, and also for your dental technician it is way more difficult to fabricate the restoration than butt joint or window preparation. So butt joint is pretty simple design, simple to prep and simple to fabricate, and conservative because of the path of insertion. And actually there is no advantage to do incisal overlap in terms of strengthening or in terms of retention, because there are some people that still used to think that if you will do anything from palatal side, your veneer will be more stable. It is not the truth, because veneer is the type of restoration that is completely relying on bonding strength, not because of mechanical strength, mechanical retention. So when you keep enamel, you have perfect conditions to have best micromechanical adhesion. So keep enamel and keep your 3 planes if it is possible. Sometimes we do incisal overlap. Sometimes, for some cases, okay, for some cases we do incisal overlap. For example, when we deal with occlusion. And I would like to remind you again about our new online masterclass about different designs of preparations, where we include also incisal overlap, and I will explain you exactly in which clinical cases we do incisal overlap and how to do this incisal overlap properly. Okay, and also window preparation, type 1, type 2, type 3, everything step by step will be covered. And regarding this support program that I mentioned, but I didn't say what kind of support program you will have. For all participants of this online masterclass who apply before 24th of June, we will create a special closed private group. And you will have to send or publish your cases there. And we will review your cases there, and we will help you with these cases there. And every single month, we will do live Q&A sessions with case reviews. I want to support you for this program and to force you and to push you to start preparing teeth for veneers if before you have no experience. For example, you decide to watch this online masterclass and then you will do veneer preparations. And I want to see your preps. And I want to help you with your preps, because my main goal, my main target is not just sign as many people for this online masterclass and to quit. I want you to implement and to use information and to use knowledge that I'm sharing with you. And the best way is to support and to guide you with this support program. And again, this support program will be available only for those who will apply before 24th June. Okay, let's continue with the rest of presentation. I would like now to share a case. So here is the case presentation, initial situation. Patient came with multiple composite fillings. So class 3, class 4, you see. We had also rotation here, okay? And you can see from palatal side how these teeth looked like. And you can see that palatal extensions from all of these frontal teeth and also some fresh caries defects. So basically, we have defects, so-called transit defects from vestibular to palatal. And in such clinical cases, there are a lot of questions regarding the selection of the type of restoration. To do veneers, to do veneer with overlap, or to do semi-crown, or to do 3/4 crowns, or to do full crowns. And I will now show you exactly what we performed in this case. Before I will continue with the clinical steps, I would like to share with you a very interesting tip. How can we solve the problem of rotation, for example? Okay, how can we solve the problem with rotation? In this case, your dental technician can fabricate so-called prep guide. I want to highlight a very important information. These prep guides can be fabricated and can be used by yourself only in case if patient accepted treatment plan. Okay, it is important. And also, you may use this technique in case when you understand that your preparation will be not aggressive. Because if you have a severe crowding or rotation, it is better to do orthodontic treatment, not to prep teeth. to do ortho, and then you do veneers. If you have slight rotation and patient has agreed with treatment plan, you can use this approach. So your dental technician may fabricate prep guide. In this video I'm showing you analog way to do this prep guide, but nowadays you can also have these prep guides printed or milled from dental lab. If you don't have scanners, or maybe your dental technician doesn't have scanner and he makes everything by hands, this is exactly how they do these prep guides. So they use so-called pattern resin. Okay, they isolate model with a special spacer. Then they made this prep guide. Then they prep tooth on the model for wax up to make this tooth straight. Then they fabricate this prep guide, and you can see how this prep guide looks at control model. This is control model, and you can see exposed tooth through this window. Okay, so this is how it looks like. Then you will put this prep guide to the patient's tooth, and you'll be able to see superimposed tooth and how to say, slightly protruded tooth through this window, and you can just cut this tooth through the window. It's pretty simple. You put this prep guide, and then you start to prepare this extended tooth until you will reach peripheral part of the guide. Simple like ABC. Okay. Now we have straight tooth. Now we do mock-up, and after this is mock-up, and after we have our mock-up, we start do our preparation through the mock-up with a certain depth of preparation. We define and we select depth cutter according to the color change. We make grooves through the mock-up, then we remove the mock-up, and then we see how much we exposed teeth. In this case actually is like almost non-prep. We just have something on canines. You can see actually on canine just small scratches here, and this one was prepped slightly, and that's it. Okay, so it is almost non-prep, but we have space for dental technician. This is the question that we discussed at the very beginning of this webinar. So we don't need to prep as much as dental technician asks in some cases. In this case we had space before, so this is additive case. It is super. It is very nice. So then we just prep where we touch the tooth with our prep guide. Sorry, with our depth cutter, and afterwards we check everything with silicone index just to be sure that we have space for dental tech, and that's it. Then I removed fillings. These fillings were old. It's not just a fresh composite that you have to remove in every single case. No. If this composite is good, was placed in your clinic or by yourself or by a dentist that you trust, so you just keep them. But in this case the fillings were very old, and you can see that we actually found a secondary caries underneath that we also treated. Okay, and there is extension to the palatal side. But when you will take a look from the vestibular part, a lot of enamel preserved, a very good substrate to bond. Okay, so for that kind of cases when defects are not huge, you can combine composite with ceramic. So these undercuts can be filled with composite, and the rest will be restored with a ceramic veneer. But if I would have the same case, but initially the defect were like, let's just imagine it like this, the fillings are huge ones. So in this case you don't have a tooth actually, it is just, you know, a small piece of enamel or something in between. So actually it is already crown that was made directly in patient mouth with composite. So that will be removed and replaced with ceramic crown or ceramic quarter crown. But in the case that I'm showing you right now, you can do veneers. Actually, it's an easy way. You just do composite fillings from palatal side, to perform proper palatal area, you can use silicone index that we used to use for direct restorations, okay? And then you have already done. You have to think about pathway of insertion, because sometimes it depends on the shape of the teeth. You have to make interproximal area more parallel or more tapered. But if teeth are plain or squared, almost non-prep, okay? So we just performed some finish lines here, all enamel, no dentin exposed, everything very conservative, and it is proved in literature that this approach works. There are many articles that you may find from Pascal Manier, by Francesca Vailati, by Marco Grechsnicht, by Didier Dici, and with a long-term survival rates. So now, instead of doing so-called three-quarter crowns like it was indicated in old times, like you can see on that slide, when you have filling from vestibular to palatal, you have to prep until you reach sound tooth structures from palatal side. And this is not veneer anymore. It is semi-crown or three-quarter crown, and the pathway of insertion is more vertical, and you have to prep more from the cervical area, and you may expose a lot of dentin, and then you may have crack from the lingual side. I'm not trying to say that you will have always crack lines from the lingual side in such a cases, no, but there is a big risk that it may happen. And it is more difficult to prep, and it is more difficult to fabricate for dental technician, and it doesn't give you significant clinical advantages in comparison with butt joint. So let's go. We have finished preparation. I went slightly intraclavicular here, like you see interproximal. Just a little bit deeper to give my dental technician space to perform emergent profile to close this black triangle. This is the tip that you have to keep in your mind. This is straight after cementation. This is lateral view, more artistic view, and this is actually the end of the clinical case that I was going to present you. And one more time, I'm inviting you to participate in our online masterclass about complete guide in veneer preparations, where we will do all practical things step by step, and you will have tons of information. But if you want more, if you would like to be more advanced and more upgraded in terms of preparations, you can come to our training center and to participate in any of our module courses on veneer preps or about just crown overlay preparations, and you will definitely have here in our BJ Academy dental force wings, or wings of dental force. So we will guide you, we'll help you, and we will make you better in profession. So my friends, thank you very much for your kind attention, and hope to see you soon somewhere. Bye-bye.